Good evening, everyone. On this occasion of Ganesh festival, which is being celebrated here in Maharashtra and all over India, I just welcome you all to this talk that we have. Let me start this with introducing the person who needs no introduction, our very own Padma Shri Professor Dr. JS Titiyal, sir. So, sir, as you all know, is the chief of Dr. Rajendra Prasad Center for Ophthalmic Sciences. He is a prolific cataract, cornea, and refractive surgeon. Sir, a very warm welcome to you and thank you for being here with us. Along with that, we have Dr. Sourabh Choudhry, who is a senior cataract and refractive surgeon at Eye Care Hospital, Noida. Welcome, Dr. Sourabh. We also have our own Dr. Vardhaman Kankariya, who is a director of Asian Eye Hospital, Pune. He is also an expert refractive surgeon here himself. Welcome, Dr. Kankariya, please. Along with that, we have our very own Dr. Mayank Sharma. He is a senior cataract refractive surgeon at ASG Jodhpur and has done many number of refractive surgeries. Along with that, we have the two moderators here, that is Dr. Fareen, who herself is a cataract, cornea, and refractive surgeon at ASG Jodhpur, ASG Aurangabad. And I am Dr. Hemant Kamble. I am an anterior segment surgeon at ASG Pune. We have our scientific team from ASG. We have Dr. Kaushik with us. Dr. Mayank Sharma, Dr. Gopal, Dr. Ganesh from ASG Bhopal. I welcome you all to this presentation, and let's hear to Dr. Titiyal for further. Thank you. Thank you, sir.
Thank you. And I'll just like to introduce our academic activities to the audience. We have had previous classes on pediatric retinal detachments, inverted ILM flap technique, vitreoretinal interface disorder, optic disc speed from Anna Naurika, who described the inverted ILM flap, and art of scleral buckling, hard cataract, art of pneumatic retinopexy, and integrity imaging and integrity in retinal detachment repair, and management of PVR, and diabetic vitrectomy. And Titiyal sir has we have a separate talk on maximizing outcomes of toric IOL, and we had a talk on retinal detachment and acute retinal necrosis also. There was a talk on idiopathic polypoidal choroidal vasculopathy and macular hole. So this is our website in YouTube, and this is the QR code from which you can access all the videos of this. And I think we'll go to sir. Thank you, sir, for privileging us and joining us.
I would like to thank Dr. Hemant for your kind introduction, and I welcome Dr. JS Titiyal for presenting us. And we all are quite enthusiastic and eager to listen to you, all the audience. Yeah, let's start. Welcome to the platform, everyone.
Sir, I'll start sharing once you are ready. Just let me know.
I feel sir is on call for him, so
yeah.
Let him complete it.
What no, they're saying you have to give me admin right, तभी हो पाएगा वो. Your जो admin है ना, he has to give me a right.
Dr. Kaushik, please make Dr. Titiyal sir host.
Yes, already co-host.
We've done that.
Sir, I think you can start, sir, with this from this.
Sir, can you see my screen?
I can see. Yeah, that's true.
I know. Uh, I think एक बार डॉक्टर कौशिक एक बार if you can just check admin right सर के पास है या नहीं, होस्ट तो बना दिया है।
पोस्ट बना दिया है।
हाँ,
ये होस्ट से हो जाता है यूजुअली।
अच्छा,
नहीं शेयर डेस्कटॉप।
ठीक। Anyway, that doesn't matter. Okay, can you hear me?
Yes, sir.
Yes, sir, we can hear you. We can hear you.
Okay. First of all, I'd like to thank you, all of you, for kind invitation for this, I think, very, very important session on a refractive surgery, because nothing important than having a very good case selection and looking for a suitability, in fact, more of a unsuitability for people undergoing refractive surgery, because this is one of the largest surgery being performed in the human body with a normal anatomy as such. In that way, we have a much more responsibility to do a good examination than the counseling of patient, and go through the important investigations which can highlight the important points based on which we can always think of making person effectively suitable for surgery. Uh, can I go for next slide, please?
Yes, sir.
Next. So this is one slide which is, I think, very, very important, summarized very nicely by Dr. Manpreet and Dr. Fareen and Dr. Shri Devi. And just click. You know that all started with long time back in the early 19th century, where people started doing incisional refractive surgery. Subsequently, yes, we had the lasers being into field, and that laser effectively, I think, would should give credit to Jose Barakar, who started doing a microkeratome surgery for lamellar procedures. Not exactly for refractive correction, what we do nowadays, but basically for a keratomiliosis. Subsequently, that gave a path for a LASIK procedure in 1990. Pelikaris was the first person to start this. Around 1999, we got a FDA approval for a LASIK. A PRK got approval in 1995. So we can understand PRK would have been the precursor for laser refractive procedure. Subsequently, around 2008, we had a first SMILE case reported by Dr. Secondo, and subsequently 2016, we had a FDA approval for a SMILE procedure, which gave us another area of refractive surgery. If you see this entire history of refractive surgery, except for incision surgery, rest of the refractive procedure based on the lasers are still almost similar. There may be some change in the profile, softwares. Otherwise, the procedure is almost similar. That gives a reflection that whatever corneal based refractive surgery we have been doing were good, and they still exist and maybe therefore remain there for a long, long time. Next slide, please. So these are various types of surgery we all know. I think one important thing which has been added now is a phakic eye wheels. In India, this came in early 2000, and since then, that has also given a good advantage for a people with higher refractive errors, high myopia, hyperopic patients. Now we all know these are being taken for a moderate refractive error also, and understanding the bioptics to cover the larger range of refractive errors, where you can combine the both procedures, laser based or intraocular lens based surgeries for our patients. This is the FDA approval for a range of refractive error, which may not be exactly applicable today, because we have so many options for correcting higher refractive errors, especially cylinder. You see here PRK says +6 diopter, same for LASIK for cylinder, which nowadays will not never go for that. We have various tools to identify subclinical keratoconus or a cylinder which may not be correctable to a corneal based procedure. You can have a phakic eye wave. So this was one of the first approval from FDA point of view, but things have changed so much now. Next. I think this is a very important slide. Age, I think we all know age should be the criteria for getting patient into this. If you see this slide here, it starts from 18 years to 21 years. But if you see ICL, it says 21 to 45 years. So that is true, in fact. But If you look into today's group of people coming to us, we do have a people with a presbyopia coming for laser refractive surgery. Therefore, the first two slides, LASIK and SMILE, can again be, given the age range can be 45 plus also, where we do a presbyopic laser refractive corrections also. Next, please. This all know suitability depends on a stable refractive error. Then next will come, patient with, some physiological problems, no systemic problems, especially collagen vascular disorder or autoimmune disorders. And most importantly, patient should understand the outcome of a refractive procedure, because we all know sometimes they don't last for a entire duration of their life. This is only for a till, suppose we correct the refractive error in a way, since the presbyopia might set in, so you have a range of 10-15 years as such. We all know the eye keeps modeling themselves, both anterior and posterior wise, especially the keratometric values. So you may have an induction of some sort of refractive error in future also. So that's also a very important part of looking into. If you see here, there's absolute contraindication, where we all know patient who may not be absolutely fit for refractive procedures, like unstable refractive error. There I normally look for a induction of a more cylindrical power. And in that also, it's not only the amount of cylinder, the change in axis is also very important. That part has to be looked into. If patient has a records of past prescriptions, that will tell you if the axis change has been much more than 10 to 15 degrees, then you have to reassess this patient carefully. Because in our days when we started all these procedure, we didn't have the topographers or tomography at that time. We are totally based on a refraction and keratometric values. So we do have a lot of now important points to be looked into, and that will give the correct assessment of these patients. I think dry eye is one very important aspect, which I'll cover subsequently also. Any ocular disorders, especially herpetic eye disease, maybe a relative contraindication in that. If you look into a patient who has some sort of history of keloid formation, maybe not very good case for a PRK type of procedure in these cases. Next. Next, please. Huh. I think here every point is very important for our making a decision. Patient examination has to be comprehensive, especially not only looking for a visual acuity and visual function. I say visual function because that's also very important part. Here we are not only correcting the refractive error to improve the acuity, we are correcting the visual function also. That looks into quality in terms of improving the MTF point square function for these people, decreasing the higher aberration so that visual acuity commensurate with the visual function also. Examination, anterior, posterior, angle, everything has to be seen as per the procedure wise. Most importantly, the corneal profile has to be checked, not only the topography. Tomography is also a very important point for these patients. In intense scenario, pupillometry may not be required, but all topographers give you a pupillary size. In Western eyes, the pupil size normally is quite big, and especially if you are doing the large corrections like hyperopic corrections or high cylinder, or you are doing a phakic IOLs, then pupil size makes a huge difference. Otherwise, rest of the investigations are almost similar. Next, please. So let's come to the actual investigation, which will change the will give the entire profile of a patient. As I said, corneal topography and tomography is the one of the most important investigation. You may use any equipment which should give us the both anterior and posterior elevation maps. Apart from that, corneal topography will be important in these cases. So if you see, this one is a classical normal topography of patient, where we are looking for a Kmax would be less than 48 diopters. Kmax difference between the both eyes would be less than 2 diopters. And most importantly, if you have a bow tie pattern, which is classically seen in the most patients, the radial axis skewing should be less than 21 degrees. I think these are very important, which I'll cover in next topography picture. If you see here, these are three pictures you can see here depicting three important points. The first one is looking for skewing axis. You can see in the right eye, the skewing axis is almost more than 30 degrees. And you can also see the inferior steepening in that patient, which is evident in the other, you can see in the right-hand side picture also. If you see the middle one, you can see that this is a superior, steepening in these cases. We all understand the keratoconus ectasia is more of an inferior nasal steepening. So if you have a inferior nasal difference, the you can see it has to be less than 1.4. So the range is slightly smaller in the inferior steepening, while if you difference between superior and inferior, then it is around 2.5 diopter or less, because we normally don't see a superior steepening in most cases. Next slide, please. So that was the difference in anterior profile wise in terms of K max and superior inferior difference is skewing. The other important parameter which we have now realized is the pachymetry, the corneal thickness, because the entire game is based on maintaining the corneal thickness to such an extent where you don't have problems. So if you look into a corneal thickness wise, the thinnest location should not be less than 470. I think that is very important point. Anything less than 470, go back please, should be the no for a refractive procedure. Other important things are look for apart from the thinnest location, you are looking for the difference between a superior inferior say and the difference between two eyes, and that is at 5 millimeter zone. You have to look for these areas, and if any difference between the superior and inferior more than 30 microns will be a important point. So the three important pictures should be seen here. One is the pupil center, second will be the thinnest location, and the difference between the thinnest location and the K central K reading, K max reading in these cases. So these 3 points will be important to consider, which will discuss. Next slide, please. So if you see these two slides of a patient, two different patients, you have a different patterns. So sometimes the pachymetry pattern also gives you a clue that there may be a difference between superior, inferior, or a thinnest location may not be appropriate. So you have the droplet pattern, which is classically seen in a central cone. Or similarly, if you see the other picture, which you can see the very significantly a steep cornea, that's a classical keratoconus, which if you see the displacement of a thinnest location is vertically displaced towards inferior side. So that also important because as I said, inferior steepening is a classical feature of ectasia, especially if you look at keratoconus wise. So in a pattern wise also is can be reflected apart from the actual thickness map in these cases, which will be evident in subsequent pictures also. So this is the normal elevation maps, both anterior and posterior. You all know that anterior elevation should not be more than 12 microns and the posterior should not be more than 17 microns. I think in this analysis, posterior elevation will be much more important to assess. Next. So if you see here, these are two important maps which you can see here. Left hand side, another patient which has a central island, and if you see, I can magnify from here. The central island, if you see the elevation is more than 17 microns there. Posterior, you can see again, it's again a steeper, around 26 microns are there. Similarly, if you see the other eye also, this is a pattern which you normally see hourglass or tongue-shaped protrusion of a steeper points, which also correspond anterior to the posterior elevation also. If anterior and posterior corresponds to each other, that is a classical feature of ectasia in a particular case. Next, please. So this we all know, the enhanced ectasia map. This is from Belen Ambrosio. In that, the top one picture is the normal topography or tomography. The second one is, enhanced map, which excluding the center 3 millimeter of topography. So your base is, flatter. So anything little ectasia gets more pronounced. So in fact, this is the, artificially generated elevation map. The important one is to see the differential map. So if you see the differential map here, totally green within normal range. So that should be the, if you want to see only single map, that should be seen the differential map, which is most inferiorly placed. The other important parameters are, next slide, please. Next. So next we'll be looking into the if you look into the thickness of a cornea from the thinnest point to periphery, so it should be ranging between the 95 to 5 percentile of a normal population. So if you have this, there's a deviation from the rapid decrease or going out of this 95 percentile, then you can think of ectasia in these patients. Similarly, if you're looking for a PTI, which is also important parameter, which is the ratio compared to the normal population, should also be looked into in pictures. Next, please. So I think this is one important point, which if you see this particular block, which has every point, you can see K1, K2, K max will be there in this patient, and importantly, the pachymetry progression index (PPI) or PPI will describe in this particular case, and anything yellow or a red will be the important point here. If you look into pachymetry progression index, that is the ratio from of a patient's own reading to the normal population. That is also a very important point to be highlighted in these patients. So all these points will be come into together in subsequently in terms of ART max. That is also to be considered. Anything less than 416 microns will be suspect, and cases where less than 340 or so, it will be keratoconus as such. PPI I've talked about, normal range is around 1.05. And this is another example. If you see the last circle here, which is a D value, which I'll highlight again. These are various points which are considered in calculation D value. Now we have some more points added like anterior, elevation, posterior, and Kmax. All together will give you a comprehensive analysis of particular case. So even you don't see the entire parameter, somebody tells you D value only, that will be the consideration, which we all know. Age of patient also will be important factor. But anything which is around 1.6 or less is a normal person, normal topography, or the sensitivity and specificity of a D value is quite, you can say, significantly better, around 84-86%, to pick up the subclinical keratoconus. I say this word subclinical keratoconus because we are not trying to see a patient of keratoconus here. We are looking for refractive surgery suitability. The only thing there important is to rule out the subclinical keratoconus, where the other parameters may be important. So this is a parameter of Corbis. Next, please. Where we have gone beyond the topographic values, where we are looking for biomechanical indices. In that, I think it's very, very important, not only for a picking early keratoconus or subclinical, it is important for cases who undergone other procedures, like a patient of keratoconus undergoing CXL, or you have done a refractive surgery and you like to see the biomechanics of a particular case after the refractive surgery also. So this CBI is very important indices, especially looking for biomechanics. But this is not a very good parameter for to pick up the early keratoconus. This is good parameter for picking up the patient with the keratoconus as such. So if you have these values of CBI, which is these are, go back. Important points is we're looking for a pachymetry indices in these patients. It's quite sensitive. And the other important point will be once you combine the biomechanics with tomographic values, that is TBI. Next slide, please. There you can have much more parameters. So you can have the topography parameter, which is towards the left hand side, and the biomechanical indices right hand side. Combined, it gives you all the parameters to be assessed. Which important parameter there would be looking for a flying ectasia cutoff is almost 0.79, 100% sensitivity. But anything less than that will be suspect cases, and 0.5 or less will be a normal cases assess if you're looking for a tomographic assessment in these cases. Next. So if you see here, the cutoff for a subclinical keratoconus is 0.29. And sensitivity, if you take this value, the sensitivity and specificity is quite good, which is around 90 and 96%. And if you look into other important parameters, we're combining tomographic as well as the biomechanical indices, the pickup of a subclinical ectasia may be better in these cases. Otherwise, it is important to see the other parameters. Yeah, next slide, please. Which we talk about nowadays, stress strain indices, which is not dependent on intraocular pressure as such. So this gives you how much is the strength of a cornea when you actually we are giving the corneal deformation with the air pressure. So this is a very good tool to assess the rigidity of cornea, which also tells you that which patient may have stronger cornea. We have used this more often in cases where it's undergone CXL to see how much is the stiffening has occurred in these patients. As the age advances, the cornea gets more stiffer and stiffer. The older age, stiffness will be much more in these cases. That's why we talk about older age, you are still safer as such. You can see it depends on how much pressure you apply to deform the cornea. That tells you a stiffness. If you do a Corbis, this will be the parameter you can see in these cases. So if you have a stiffer cornea, so you may be much safer. In those cases where your corneal thickness may be around 500 or around, because we don't know, sometimes your cornea may be 520, but stiffness ratio may be less in those cases. Your cornea may be only 500, but stiffness may be better. So you are still safer in these cases. So this value will be important where you have a borderline pachymetry where we are little doubtful or a parameters are little doubtful. So this parameter can be assessed in these cases. The SSI can be a one parameter as such. So this you all know the cutoff parameters. We normally keep residual bed thickness more than 300 microns after making the ablations. The flap nowadays is 100 standard. Earlier we used to do 120 or so, and 100 110 flap is quite stable in most cases. Also, people have gone to 80 micron also. The PTA is also very important parameters, which normally calculated, as you know, the flap thickness plus ablation depth divided by central cornea thickness, or anything less than 40 is acceptable for refractive procedure. Characteristic value is also very important. Should not be less than 34 or more than 50 if you are looking for cases of hyperopic corrections. Single parameter may not be important for a decision making. You have to take everything together and then assess these cases as such. So I would rather go for all three parameters together and see which is a suitable option for patient. Next, this is the phakic IOLs, which you all know. The considerations are almost similar for the available phakic IOLs nowadays, Indian or ICLs. The depth, people say 2.8 ACD from endothelium. We normally take 3 millimeter as a safety margin in these patients. And it is important to realize the other important parameters, white to white and the endothelial cell count. And these are parameters for suitability as such. Next slide, please. So this is one area of concern, as I talked about in the beginning. Let me just take you through the dry eye and the patient undergoing refractive procedures. Large number of patients would have some sort of a dryness who are coming for refractive procedure as such. Younger patients are not free of ocular surface disease or dry eye, especially if they are contact lens users. And the assessment has to be done in these patients very, very carefully, especially looking for the BOT and corneal and conjunctival staining in these patients. Next. So this is what we are looking for. This has to be noted: irritation, pain, dryness, discomfort, blurred vision in these cases. And one important examination is BOT in such patient, apart from the Sharma's and the thickness of a lipid layer, if you're doing the other parameters in these cases. Next. This is what we talk about. Not every patient we do assessment of these, but if examination tells you, you must do these investigations, because it is important to document all these parameters, especially those patients who have a very significant dryness, MGD, inflamed eyes. You can do other investigation like hyperosmolality or MMP9 can also be done. And some people like to look for a cytokinin detection in these patients. which may not be required for all patients, but should be done in some patient where you feel the patient has an inflammatory dry eye as such. So this is what we look for. If you pick up a dry eye in your patient, don't jump for surgery in these patients because your topographic values may be variable. Your refraction may be also variable in these patients. Treat these patients and then proceed for a laser procedure after 4 to 6 weeks, which we have, next slide, we have studied a group of patients undergoing smile and LASIK procedure, where we started the topical cyclosporin and chloroquine in two different group of patients 5 days before the surgery to have a baseline uh, of availability of a cyclosporin and topical chloroquine in these patients. Then they underwent, this was for all patients, not only for dry eye patient, all patients went this protocol. And we realized after surgery and after 3 months, 6 months, the corneal profile as well as the quality of visual acuity are better in those patients where we had given the topical chloroquine or a topical cyclosporin along with the routine treatment in these patients. So this signifies and uh, tells us that if you control the ocular surface beforehand and in subsequently also when patients are on a post-op management, if you have these anti-inflammatory drops, these patients have a better outcome as such. So that's a very significant point which we need to assess. So if you have a dry eye, yes, it has to be treated at least 4 to 6 weeks before you do surgery. But normally, this is a very, very handy and useful substitute. Next. So this is another point we always talk about. A patient of myopia, sometimes they have, we all take them for a posterior segment assessment, look for any other problems in these patients. Some patient may have predisposition for retinal detachment, which you all know, and a pre-existing tear hole lattices, which may be symptomatic in these patients, PBD induction, which may increase subsequently if you do a classic type procedures, and these patients would require the subsequent surgery also. Next, please. So this is what we think. Which are the patient who should be treated immediately? If patient has a horseshoe tear or operculated holes, lattice degeneration with retinal holes, atrophic holes, these patients should be treated immediately before you jump for a surgery in these patients. Symptomatic LASIK, some people keep observing these patients, especially if we do a non-pressurized surgery like PRK, and though treatment is recommended for these patients also. Other group of patients are asymptomatic patients. Again, there's a debate. If you have a large lattice, sometimes people do treat these cases also. Sometimes they keep observing these patients. Every patient should be seen subsequently to their surgery also, maybe within a month or 3 months. And there should be a long-term follow-up with these patients to look for all the aspects, not only the visual acuity, the posterior segment should also be assessed in these patients. Next, please. So this is the algorithm I have picked up from one of the articles where we look for a posterior segment screening for all these patients, and it is, I think, important. If you have no pathology, then you can proceed for surgery. But if you have retinal problems, especially detachment macular, sometimes you can pick up the unidentified detachment happening in these patients, macular disease, or a patient has angiostic traumatic damage to the choroids, diabetic retinopathy, then refractory surgery out of question for these patients. But peripheral lesions should be treated and should be reassessed after treatment, maybe after 3 to 4 weeks, and look for a completion of a laser, a scar formation. If that is complete, you can take the patient for surgery. If it is incomplete, then you have to redo that area. Then again, wait for 3 to 4 weeks, and then proceed for refractive procedure of these patients. I think this is very, very important point for all people to assess. Next. Now, the other points are what are the important things we discuss here. I'm just trying to comprehend all of them. Apart from the manifest refraction, we are looking for a patient's profile, patient's expectations, and the type of requirement, because many patients not only come for cosmetic purpose, they come for a various requirement for job purpose also. patient may be going for to become a pilot, railway engine drivers, deep sea driving. Those things also should be highlighted in your history wise also. Corneal pachymetry is important point which we discussed, and the if you are looking at faking iris, AC depth and wide to wide are two important parameter as such. Next, please. So this is what chart says. So if you have a less than 40 years, myopia less than 14 diopters, hyperopia less than 6 diopters, with calculation, your RBT is more than 300 microns, your keratometric within the normal range, you can do any sort of procedure, which may range from faking iris to LASIK PRK smile. But if you have a high refractive error, then faking iris is the important, I think, dimension for these patients. Though nowadays we consider faking iris for a moderate refractive error also, especially those cases where your corneal parameters are borderline. If you have patient more than 40 years, we are discussing another group now. You can think of a clear lens fixation in those patients where you have patients, angles are narrow, AC depths are narrow, where you can't do a faking IOS. You might go for clear lens extraction for these patients. If you have patients, sclerosis happening in the nucleus, your DLI is less than 5, or you have a lot of internal aberration, then no point doing refractive procedure onto the cornea or in the posterior chamber implantation. It has to be a clear lens section for these patients with the multifocal IOLs nowadays giving so much of good results. This is what I've highlighted in the next slide. Next, please. So this is what we talk about. Mild to high myopia. You can go for a femtosecond LASIK. For PTA less than 40, PRK can be another substitute nowadays for all patients. Many people do a PRK for almost all range of refractive corrections. As far as I am concerned, I normally don't go for higher refractive errors with a PRK, and my limit is around 3 to 4 diopters, and cylinder up to 2 diopters for PRK. Same holds true for LASIK and SMILE also. The the basic parameter I highlight again also. Next, please. So this is another decision-making tree I have made, similar to what we talked about, same as before. Next, please. So many people ask, what should we do? I think this is what we discussed also. Should we do SMILE, LASIK, or what will be the choice? What are the points which will be, which will shift your decision to one procedure as such? So if you have a patient with high myopia, around -6 to 1 diopter cylinder, so this patient, because cylinder is only one diopter, you can, next slide please. So you can go for a SMILE or LASIK in these patients. Especially, I might choose SMILE, prefer SMILE in these cases, because SMILE would definitely induce lesser higher aberration in these cases, because the larger, optic zone in these cases. Because if you are treating more of a spherical, you don't have a transition zone as you have in a LASIK profile also. Next is the astigmatism. If you have a higher degree of cylinder, like if you see this example, -6 with -3 diopter cylinder, I might prefer LASIK over the SMILE in these cases with the Bizumax 500, where we don't have a tracking system, which now with the Bizumax 800, you might go for a 3 diopter cylinder in SMILE also. But today, if you have only 500 with you, the LASIK will be a preferred option for these patients, because higher cylinder correction would have some regression happening in these cases, and you may have to redo. Redo is simpler in a LASIK patient than SMILE, though resurgery can be done safely in SMILE also. You can always convert the cap to flap and do a reprocedure also. Moderate dry eye, next slide please. Again, the SMILE will be preferred choice than a LASIK in these patients. And the last point, which is a debatable issue, the corrective values are little on a borderline. A flatter K or a steeper K prefers SMILE than a LASIK. There has been a few reports where the amount of a central keratometric change happening is less with the SMILE than the LASIK patients. So that may be one factor which might shift or decision toward the SMILE for these group of patients. I think these 4 points are very, very important to tilt your decision to one or other side for patients. Next. Let me take you a few examples of a patient. This is the young patient, 22-year-old patient with 4.5 diopter spherical, 1.5 cylinder, almost in the other eye also, 6 vision with glasses. Next slide, please. If you see this topography of a patient, right eye and left eye here, this is almost quite evidently looks all right, but PTA is 41 in right eye and 30 in left eye. The RBT is 292 and 297. So pachymetry definitely concern in this patient. And if you look into a displacement also, and D value, you can see it higher. So this patient, though, if you just look into anterior and posterior values also, it looks quite all right. Even the Berlin ratio enhancement is a green again. But other parameters, the pachymetry parameters are not exactly suitable. So this patient you can label as a subclinical keratoconus, or these patients should be reassessed after 6 months or so to look into any change. And if there's a progression, you should avoid laser refractive procedures for these patients. Next. So this is what I was talking about. This is another patient, young patient again, 3.5 with one cell. Left eye has a spherical power only. Next. You can see this is a normal looking topography picture, both left and right eye. Next. Next, please. But if you're looking here, again, just in the left eye, you have a small centered yellow picture coming in the differential map. So this also indicates there may be some difference in the steepness. But if you go back again, go back, please. But if you see the D value is normal in this patient. The bad is normal, but there's a small center island. So that may not be exactly the ectasia which we are looking for. In such patient, we are looking for epithelial mapping in all these cases. If you see epithelial mapping, there's a thinning in the inferior epithelial thickening is there here compared to that area of ectasia happening. If you see here, go back here. Karin, can you go back once? Yeah, if you see here, there's an area of you can see a yellow spot, which is the elevation correspond to the thickening of epithelium. Next slide. Thickening of epithelium. So that may be because of localized thickening, and this patient may be suitable for refractive procedure. Next. So this is a classical example of a keratoconus. You can see the central map, which is totally red. And if you do a epithelial mapping this patient, this will also, the thinning will correspond to the ectasia part. And there's a thinning of epithelium here rather than thickening of epithelium. So that tells you that it is a typical keratoconus patient. The previous case was it's just epithelial hypertrophy, not the ectasia, and that patient can undergo refractive procedure. Next, other important point which needs to be highlighted is a patient wearing contact lenses sometimes, and long contact lens use can have a contact lens warpage. That's why we normally would like to assess these patients after a few weeks of stoppage of contact lens. For a soft contact lens, maybe 2 weeks. Many people do within a few days also. For a patient with a rigid contact lens, you definitely have to wait for longer period. Now we have MS39 also, which gives you a good assessment of epithelial and the stromal map also. And this is a classical example of epithelial hypertrophy happening in this patient. You can see right eye is the central steep island in Berlin Ambrosio, and there's a thickening in the epithelium in this patient. But if you look at the stromal mapping, which is the middle below a red arrow, is a stromal mapping is normal. So if you have these type of tomographic equipment which can give you separate the epithelial and the stromal mapping, then you can analyze much better cases with epithelial hypertrophy and rule out the ectasia from these patients, or you can pick up the normal looking patient, and these patients can undergo refractive procedure. And this epithelial mapping is also very important for those procedures where going for a transepithelial PRK, where the epithelial mapping has to be done in a very appropriate manner. few points regarding the customized corneal aberration. You all know wavefront or a wavefront guided optimize can be done nowadays. Next slide, please. People talk about topo guided or contour corrections, which depends on the appreciation or a pickup of the maps, which is done by either the topolizer, and that map, next slide please, should be suitable for getting towards the actually mapping should be such where you can have a good titration, and there should be each map should be accountable for a correct orientation. Next please. So these are how we are going to correct these patients and look for a higher operation, then go for a particular type of treatment in these patients. So once you are looking for a patient with good visual acuity and has a normal hydroabrasion, you can do optimize, which is the almost 90% of cases we do in wavefront optimize. The important clue is when you have a patient symptoms, sometimes they have a glare halos, the visual acuity maybe 20/20. These patients may have a hydroabrasion, and do a wavefront analysis of these patients. Anything more than 4 HOA, then look for which type of HOA they have. Corneal, internal, and internal can be separated. If you have more of a corneal aberration, then you can go for a topo-guided treatment these patients. But if you have a internal aberration also, then we have to go for a wavefront guided ablation for these patients. The topo-guided ablations are not for every patient, where they are looking for a little bit of a peripheral aberration happening in the cornea, patient having a cylindrical power. Next. And absolutely good map, like this patient has a very nice corneal topographic map. Next. If you see, these are pictures, all 6 pictures are almost similar. So this left eye is suitable for a topo-guided ablation, while the next picture you saw, all the 5 pictures are totally different. They don't align to each other. So this patient may not be suitable case for a topo-guided ablation as such. So topo maps are very important for a topo-guided ablation for these patients. Next. Next slide, please. So if you look into various outcomes, so why should we talk about contour vision or topo-guided? It seems that as the post-op time increases, the visual acuity seems to increase in these patients, or there has an enhancement of quality of vision for these patients. I think especially night driving is better been predicted, or people are reported with a topo-guided or contour vision assessment for these patients. Next, please. So this is what important. The patient expectation and the motivation is very, very important, because sometimes a patient's motivation is can be very, very high, but your parameters may not suit those patients. So that is a very difficult time for counseling these patients. And we recently looked into psychological profile of our patient undergoing refractive procedures, and we have picked up various types of people where the outcome may be absolutely good, but they are not still satisfied. So psychometric analysis can also be done for these patients before surgery also, so that you know that which patient may have subsequent problems. The pre-op workup screening is very, very important for these patients, and which entire thing you can go through our books also, which summarizes most of the points. The idea of discussion of this was to highlight some of the important points, which are very important and critical for avoiding complication in a subsequently post-op period. Fortunately, we don't have many patients where we have complications. The complication of refractive surgery nowadays is absolutely negligible, because the screening has become so, I can say, so much predictable to pick up the cases where we can, avoid refractive surgery. Thank you for kind listening, and thank you for sharing my slides, Dr. Fareed. I can see Dr. Sarita Berry there. Huh? उसका नाम आ रहा है.
Yes, yes, yes.
Yes, sir. Thank you.
आपका क्या काम, आप तो रेटिनल सर्जन हो.
नहीं सर, कुछ तो पता आना चाहिए ना, and your talks are so good and so clear, so we can learn. That is why. Thank you so much, sir.
Yeah, any points you like to put the people as a panelist?
Yes, sir.
Dr. Vardhaman is
Uh,
not there.
yes, sir.
Sir, he said
Dr. Vardhaman.
Achha.
he might be late.
Okay. So, sir, first of all,
Yeah,
thanks for
Dr.
a
Mayank.
very elaborated and very nice presentation. I would just like to discuss on, it's a very commonly asked topic by all of our stalwarts as well as the fellows. How do you rate PRK, and what are the challenges do you feel like we have to take care of in PRK?
I think good question, because if I see my own journey into laser refractive procedures, and we are actually not for a PRK for a as a primary surgery for most of our cases. We have done. We started with doing alcohol assisted LASIK first. Then we had the epikeratomy subsequently from Boria. But we knew that for a correction of higher degree of refractive errors, we did have challenges for these patients, especially the unpredictability on a first few weeks of surgery, because the acuity of some patient took almost 4 to 6 weeks to recover to a pre-op level in these patients, and some patients did have little bit of haze coming subsequently also. So I normally keep error spherical equivalent less than 3 or 4 diopter for my PRK patient. And nowadays we all shifted to transepithelial PRK in these cases, and apply mitoversin C in all these cases. So the average calculation for us is around 10 seconds for a less than 2 diopter of correction. Then subsequently add 10 seconds more for any extra degree of myopia. If a patient has 3 diopter spherical error, then I normally put for around 20 seconds for these patients. Otherwise, pain is another consideration which is severest in these group of patients. And despite the concept of using a contact lens which is dipped into a diclofenic or acular, the pain still is there in these patients. And the epithelial remodeling has been absolutely sometimes very unpredictable in these patients, young patients. I've had a patient where first 2 weeks patient was 6665, and next 2 months patient had dropped to 618 because there was a huge epithelial hypertrophy happening in these patients. So long-term steroids and long-term anti-inflammatory is required for all these patients of PRK, where in LASIK and SMILE we taper the all these steroids within a first 2 to 3 to 4 weeks. But in a PRK patient, I continue a steroid and subsequently shift to a milder dose of steroid for at least 3 to 6 months sometimes. So that is another consideration. Some patient may be become a steroid responder, and it becomes very difficult in a myopic patients.
Thanks a lot, sir, for such a nice elaborated explanation.
Yeah.
And just to add, what has been the experience with trans PRK compared to PRK nowadays? What is the add-on this benefit from trans PRK?
I think now, effectively, that's become a simple procedure because that's avoids the use of alcohol or a manual, epithelial debridement, which has its own problems. And with trans epithelial PRK, the only thing is you have to do a epithelial thickness mapping beforehand. If the mapping is good, the difference doesn't increase more than 5 microns from center to periphery, then it's a very good case. There are cases where we tend to avoid transepithelial PRK also, where the epithelial thickness is irregular. And also it depends which machine you are using. If I'm using the wave light, then there's some limitation in terms of titration of how much your epithelial transepithelial procedure you can do. But if I do in a Visumax 500, then Mel 90, then their titration is better. So I normally prefer nowadays Mel 90 for doing a transepithelial PRK.
And any experience of, sir, epithelial haze and regression in trans PRK compared to LASIK?
Definitely, if you compare to LASIK, there's definitely, as I said, sometimes we do have patients remodeling happening for a very, very long time. I remember one or two patients where we had a little bit of stomal area, but that is got like you have a button holding in a flap. There's the stomal area leaving when you do a transepithelial PRK, especially if your mapping is not ideal in these cases. And some cases, if your mapping is not good or your thickness is variable, you might do an alcohol assisted PRK in those cases, or a LASIK, because you have a very smooth stomal bed in these cases, and you're 100% sure that you remove the epithelium, which sometimes is a challenge in a transepithelial PRK.
So, but still, I feel, sir, with the experience coming on and doing more cases, trans PRK would be a better option than this PRK, alcohol
Yeah,
assisted.
definitely, definitely.
Yes, sir.
Because
So
I'm
there was a question. Yeah, yes, sir. Please continue.
because I know that we are all going to shift to a transepithelial PRK, because that is a single stage procedure, and the results are quite good, and laser is taking care of both the things, and the concept of apoptosis, other things will decrease subsequently.
Okay, sir. Thank you. So there was a question in our chat box. Doctor asked about the contraindication for keloid.
That is not every patient of this age group will have the keloid formation, but we do have some patient having keloid. It's not really contraindication for a now the modern surgery, like femtosecond LASIK or a smile procedure. It could have been with a microkeratoma earlier or a PRK. I still feel we may have a challenge in those cases, because healing is definitely different in those group of patients where keloid formation is happening. Though I personally I don't have any experience of having such patient coming to our practice, but it's written books, so it is highlighted.
Yes, sir. Yes, sir. Thank you, sir.
Yeah.
I
I
think
would
there was
like,
another question
yes.
also, sir. Is pregnancy or planning for pregnancy is a contraindication? The question was from Dr. Swati Jain.
No, planning of pregnancy is not a contraindication. You can always plan well, because pregnancy will definitely change your entire physiological and metabolic profile of your cornea. So that's why we say, if somebody is pregnant, then that's a definite contraindication. You should not do at that time. But if somebody has, like postpartum, at least you should wait for 6 months before you think of doing procedure. Even 6 months is a little early. I would wait for almost a year, then do. And in the meantime, assess the refractive and corneal profile for these patients. If things are stable, you can still consider for doing surgery. If you are planning for pregnancy, then again give a gap of at least 6 months before you go for a pregnancy as such, because we know that many people have a little bit of fluctuation of their refractive correction, and they don't come back to normal position. So that's the only concern. If somebody has had a change during the pregnancy period, after gone through the refractive procedure, maybe 1 year, 2 year, 4 year back, there can be a shift happening in these patients, and many patients will not recover back to the normalcy in this case. So that's a very important profile.
All right, I think
Arun,
Dr.
please
Vardhaman
read
has
the next
joined.
question.
Dr. Kaushik.
Yes, I think we have joined. Dr. Vardhaman has joined. Actually, there was another question. What are the risk factors for overcorrection after LASIK in myopia?
Ah, the major problem of undercorrection, overcorrection can be blamed to a initial investigation, especially the refraction, manifold refraction, because that's the most important part. So you require a person who's expert in doing refraction, and especially doing the correction with fogging. Sometimes fogging is a very important point, and you must have a duochrome test being done in these patients, so that you don't overprescribe or underprescribe in these patients. So I would say overcorrection, undercorrection, the main cause is the initial refraction. which may have been a little, incorrect sometimes. As far as on table concern, sometimes if nowadays with the newer generation ablative procedures, the time taken is so less. So you don't have a change happening in the atmosphere when you are actually doing ablation. Initially, when we started, the ablation used to take 2 minutes, 3 minutes sometimes. In those 2 3 minutes, your hydration of the cornea, your profile, everything changes, and your correction also gets modified. So that point is not very important now. The environment which is there, or sometimes in the post-op period, if you have some problems like epithelial hypertrophy happening, or there's some sort of intraocular variation happening in these patients, that may be factor, or some anatomical factor. Patient has a dryness, because whatever we do, fluctuation of vision, change in refraction in a normal patient who undergone a good procedure would be some sort of a ocular surface disorder. So that should be looked into before you look for other things. So I'll do a complete analysis of ocular surface. Treat that. Most people will get corrected with that only.
There was another question. What is regression percentage in routine LASIK follow-up? Is there a relation in amount of refractive error treated and recurrence of refractive error in 1 to 2 years post-op?
I think I did say something on that. If I have to correct the refractive error, which is more of a spherical error, the chances of subsequent regression is quite less. You should have a higher cylindrical power attached to the spherical error, then you may have little chance of recurrence, or which you call reappearance or refractive error, or a regression which talk about. Regression is classically seen in the PRK patient. LASIK and SMILE, the regression is very, very minimal. We hardly see regression happening in these patients. Whatever is there may be under correction, which may be possible in these patients. But regression is classically with the PRK patients. And other important thing is the change happening in a corneal profile. As we know that we are all, if you have a astigmatism, we all younger patient will have a more of a with the rule astigmatism. As the age advances, you are shifting towards against the rule. This shift in a keratometric values can also be a long run can induce some sort of refractive error in these patients, that to a cylindrical power. The higher the refractive error, higher the cylindrical power, the chance of regression or reappearance of refractive error is much more in those group of patients than the patient with a lesser refractive errors. But important consideration is cylindrical power in this case.
There was another question. What will be your procedure of choice in a patient 42 years old with presbyopia and a plus 1.5 diopter of hypermetropia?
Any patient with hypermetropia, you have only one choice nowadays. That is LASIK, and that can give you a good results. As far as SMILE is concerned, we still don't have the good predictable hyperopic correction being done in SMILE procedure. Therefore, I think LASIK is the one which is important in these cases. And if patient is presbyopic, if patient has can adapt to a monovision, you can go for nowadays the correction of monovision, or you can go for a uh, correction which can give you a good assessment. I normally don't go for a other way of correcting. Monovision also is not my preferred choice in these patients. I normally go for a clear binocular vision for these patients, because many patients don't accept the monovision unless they have been doing this for a long time. I know many people have a monovision concept and they practice that also. So these patients can accept your monovision.
And one more question was, what would you do in a patient who is coming at 38 years of age for removal of glasses?
Again, these patients, I would counsel these patients effectively first. Amount of refractive error they have is very important. There are people who have just -1, 1.5, or I tell them this is a very good refractive error for you, which will give you a freedom for near glass for next 3 4 years. Then you can decide whatever you want to do it. But many people are very adamant for getting rid of glasses. The first option for me is make them free of distance correction required for these patients, which we have a very nice predictability for correcting the distant refractive error. Near again, either they have to go for glasses, or then again I look for the correction which may be little monovision for these patients. We need to see these patients, especially higher myope patients, because they would have little difficulty in near as time passes, and they can also have a little bit of nuclear sclerosis. Sometimes they can have the lens getting little aberrated also. If DLI is less than 5 and the internal aberration is quite high in these patients, then these patients can be counseled for a clear lens extraction with trifocal or a multifocal or a EDOF lenses as such. But I have done patient even a 45, even now recently I've done a 51-year-old person also, corrected for distance and near use glasses. Because whatever presbyopic laser correction we have, I'm not very happy with them.
There was another question, sir. A patient, 37 years old, 10 years post PRK, who presents with a regression of minus 0.75 diopter spherical error. Pre-op refraction was minus 4. Current pachymetry is 530 in both eyes. What would be your approach? Age is 37, 10 years post PRK.
No, I'll talk to that patient, explain everything, take the patient for tea, coffee, or lunch, because minus 0.75 will be so good for her, at 37. She'll be free of her near glasses. And distance, normally ladies don't wear glasses for distance. But yes, if she's adamant, we may go for a little patch up for this. 0.75 you can correct with a PRK also in these patients.
Right.
But it will be a very good refractive error for her,
Yes. Dr. Amrita has a follow-up question on the case we discussed for a hyperopic patient, which is presbyopic also, the plus 1.5 hyperopia with presbyopia, 48-year-old patient. She's asking if we would consider a clear lens extraction with a trifocal IOL for this.
No, just for a plus 1 diopter distance.
42-year-old plus
plus
1.5
1 near,
diopters
maybe around
here
plus
and
2 for her.
presbyopic. Yes.
So effectively around she must be might use plus 3 or so in the effective power wise.
Yes.
So sometimes that can be thick, and many patients may be a little not happy with those thick glasses also. And if you understand the complications of clear lens excision, we know that some people hypros may not have that complication of posterior segment problems. But today's my point is, whenever we create pseudophakia, this pseudophakia is not going to give a clear visual acuity for more than 5 or 7 years. Many patients would require a YAG laser capsulotomy in between, and that disrupts the anterior posterior compartment, and this can create some more problems. And the capsular bag as such gets contracted, fibrous. We don't know what happens in the long run. As far as I'm concerned, if you can avoid lens surgery and maintain the patient own accommodation, because at this stage he'll have some accommodation that can maintain for a long time. The other thing which we have been doing is, if patient has AC depth of more than 2.8 or 2.9, in such cases sometimes you can go for presbyopic phakic IOLs, which are diffractive or trifocal phakic IOLs. That can also give a advantage for next 4 or 5 years, and then if the lens get sclerosed, you can do a surgery also. So that option can also be there for these people.
Hello.
Sir,
I think Dr. Vardhaman has also joined.
Hemant is asking something.
Yes.
sir, I just wanted to ask was, now that you moved from microkeratome to femto LASIK, how do you compare microkeratome with femto? I mean, we still do microkeratome LASIK at centers here. So how has been that the experience that you had, sir, and how do you compare both of them?
Actually, I can't really say anything, because we abruptly stopped keratome and shifted to a femtosecond totally. So I know that you people never had experience of microkeratome flap making in RP center, because we totally stopped that. And yes, there is no comparative study from our side, but whatever we did, Both surgeries were quite predictable. It depends which type of keratome you have, and the newer generation keratomes are very predictable. They can be within 5 to 10 microns of your flap assessment, because whenever we are calculating PTA, your flap thickness is also very important parameter. And keratome, if you have plus minus 15-20 microns, your borderline cases will be haywire sometimes. In that way, femtosecond gives you within a 5 microns difference. So you're still on to the okay range for a little borderline keratometric patient. But as far as refractive outcomes are concerned, there has been no significant difference. Whatever studies people have given, the results are almost similar. In fact, if you look into this electron microscopy studies of surface, the microkeratome surface is better than the femtosecond surfacing. If you look to early generation femtosecond lasers, which may be now almost equal now with the newer generation lasers, but still the keratome surface will be much better than the laser. In that way, yes, your refractive outcomes in terms of quality of vision should be better with the keratome. The only problem with the keratome is the flap may not be regular sometimes. The thickness doesn't get equal from the periphery to center, and people tend to reuse these blades sometimes. So each flap making the thickness variability is there, and whatever cluster problems are seen, that will be more in the microkeratome, like DLK, which is classically seen with the multi-use keratomes, which I have hardly seen in a femtosecond laser. Any flap related inflammation we have not seen at all in the femtosecond laser. So that's the advantage would be there. Otherwise, the flap addition, the stronger additions are not a concern at all. They're almost similar.
Thank you, sir.
By Dr. Sujit, classic or PRK, which one is safe for nystagmus patients?
Nystagmus.
Yeah.
As far as nystagmus is concerned, it hardly makes difference when you're actually putting the laser in the eye, because they are not supporting the eye at that time. For making the flap, because eye is fixed, so it's not going to make a difference. You can still create a very nice flap in these cases. Only thing is when you are actually ablating these patients, so you need to know the null point of these patients where the eye is going to be stable. Or when you're actually making the laser, you can have a suction apparatus also to fix the eye, light suction, or you can use your 2 hands to fix the eye by holding two limbus and making stable. But the nystagmus sometimes can be very very strong, so it hardly but makes a difference LASIK or a PRK as I am concerned, because flap making is simpler in a nystagmus patient because we're putting suction there also. But for resurgeries, other things, LASIK will be better, because I don't want to put a PRK, the subsequently PRK, and that will enhance the haze formation. And the secondary procedure are never as predictable as the primary procedures. If I do a second PRK in a patient who already got PRK, then the results can be little unpredictable, which is much more better in the LASIK cases. You just raise the flap, you can do a ablation, you get quite a predictable results in those cases. So resurgeries is best with the LASIK patients.
Right. Dr. Sabin has a question. He's asking minus 1.25 diopter error, 22-year-old patient with dry eye. What is the procedure of choice?
As we discussed, dry eye would be there in quite a number of patients. It is we do pick up and treat the dry eye first. So I'll have all the profile. I'll do a BUT, Sharma's, do the lid assessment in these patient gland dropouts and the lipid thickness. If needed, if patient is slightly more dry, I can assess the other inflammatory parameters also. Treat this patient for at least 4 to 6 weeks. See how things have improved. What will the refractive change, keratometry change in these patients? If things are not improving, I might avoid doing surgery for this patient. Wait for longer period. If things have improved, I'll do a primary choice will be in these patients will be the smile if possible, because PRK will also induce a severe dry eye in these patients. Same with the LASIK also. So if you're given a choice between smile, LASIK, and PRK, I might pick up the smile in these patients and treat these patients for at least 6 months to 1 year with anti-inflammatory medications, because that is one of the most important part in these cases.
Dr. Sujit has a follow-up question for the patient that we discussed with nystagmus. He's asking if we can go under LA. Is it the correct way? Giving
Under?
a local anesthesia. Block.
No, we know that the fixation is the most important point for a ablation to get corrected. The fixation has to, once you give a block, then you are never sure how good fixation is. In that process, you might lose. So I'll assess the what is the null point in these patients. Try to be in that area, and take your two forceps, which may be two limbs or this thing. Ask patient to look towards a light and try to fix there, because that will give us some coordination for these patients. Block a patient will not be able to fix. It is your physical movement of eye towards the pupillary center, which may not be exactly true. If patient has a very severe nystagmus, then you should not be doing. If you can't really have the good null point in this patient.
Right, sir. There's another question asking about results of PRK in hyperopic patients.
I'm sorry, because hyperopic PRK I have not done, because you are doing a peripheral ablation for these patients. Unlike in myopic corrections, you are doing more of a central ablation. PRK for a hyperopic will go beyond the 8 and 9 millimeter. You're going to damage the peripheral area of limbal areas. So these patients will definitely have a dry eye, lot of regression. The PRK is not a very suitable option for these patients.
Dr.
Right.
Vardhaman, do you
Doctor,
want to take this question?
No, I think everything that sir has said so far, I think, of course, my opinion is the same. The only thing I will probably add to is that we have done few smile procedures on nystagmus. Of course,
Okay.
as sir said, that we should not actually do it on people who have very severe nystagmus. But for people who have subtle nystagmus, smile works very well, because you have a mild suction which is actually keeping the eye in its place, and it is going to do, I mean, basically as against the examer laser, where there is still going to be some amount of nystagmus. When you are actually doing a smile under suction, the ablation is as good as a regular smile procedure. So that is number one. Of course, for the dry eye, as sir said, smile is again my go-to choice always. And for PRK, especially as sir has said, in the periphery, when you are actually doing ablation, there is going to be the main reason why hyperopic patients regress is because of the epithelial hyperplasia. And this epithelial hyperplasia is seen much, much higher in PRK as compared to LASIK procedure. So hyperopic patients are actually not a great choice for PRK. In fact, there is a new study which has come by Moshirfar also, that even if you have astigmatism more than 1.5 diopters, typically LASIK or topoguided femto LASIK will be a choice rather than doing a surface ablation.
Yeah.
So yeah, this is, I think, some of the things that I have heard so far. But yes, great inputs by sir always.
Dr. Sabin has a follow-up question on our minus 1.25 diopter myopic gentleman with dry eye. He's asking if we can put a phakic IOL in this patient, because the patient is not responding with dry eye post-medical management also. So is that an option?
Then for a minus 1.25, faking eye will be a challenge. Many
Very thin line.
company may not be able to give you that lens also, and this patient's visual symptoms will never go off, because dry eye is going to continuously harass this patient with symptoms, and the patient will never be happy with whatever we do. And any surgery, like we do a very small incision cataract surgery from a temporal side incision, which is 2.2, and dry eye patient will hurt you for next years, because that symptom doesn't subside at all. And that would hold true for faking also. You are doing 2.8 to 3.2 millimeter incision, going to cut more nerve plexus from that area, and it might compound your dry eye subsequently also. So both the LASIK or PRK or SMILE or a faking eye, dry eye patient will always be a challenge. And maybe you can avoid surgery for as long as possible for these patients until they, you can say, settle down. And I know that once we do a surgery, their dry eye going to again come back, and which will be much more difficult to treat. So you have to be very careful for these patients.
Right, there is another question. Patient who's age 54 years old and is very determined for LASIK, and can we go ahead or not? Age is 54 years old.
Yeah, but why not? If patient is adamant, if the parameters are okay, if the lens is absolutely clear and no deformation in terms of a higher order operation, I'll do LASIK for this patient and correct him for make him absolutely hematophysical distance. He'll be very happy. The only thing is we have to tell them the problem associated with a 50-year-old person. Again, the ocular surface will be challenging in such cases. So that has to be assessed. In fact, I keep telling my people, any patient coming for a refractive procedure or a cataract surgery, you must put a fluorescein into the eye. And that delineates everything, and you can show the picture to the patient. You have this punctate lesion in your cornea, you're not suitable. That is how they understand. If you show this punctate staining in a post-op period, they'll blame you. It has to be beforehand.
Right, right. Dr. Vardhaman, what is your experience with LASIK or any refractive surgery? What is the maximum age that you have done any ablative procedure for a patient?
So basically, let's say that as Sir has said, if I think for people who have access to eye trace, it is a great tool basically because everybody is going to age differently, right? So basically, as long as the patient has a DLI index.
I think you're on mute.
Second thing is, example, if the patient actually doesn't have any lenticular aberrations that we see on DLI, there is no actually higher limit. We have done LASIK on patients who even in the age of 55, 57 as well. But the thing is, of course, that monovision doesn't work great in them because they already have lost a lot of accommodation. So as sir said, actually, if these people are into driving, we always try and push them for distance only corrections. If they are very keen to actually have a reasonable or functional or social reading vision, I put them on contact lens trial for about 2 weeks time with monovision. If at all they are actually reasonably happy in that time frame, then only we go ahead with that. Then they also understand what they are getting into. So there is no real upper limit as long as I think you have the right way to assess the patient. Second thing I will tell is basically there is a age limit for me for smile though. I actually avoid doing smile after the age of 40s, and I think there is also a study by Alio. It is I think published in JRS, and they have looked at smile outcomes before the age of 35 versus after the age of 35, and somehow they have seen that the smile people that I mean because the let's say the stromal healing is required in smile is slightly different way than the femtosecond LASIK. So they have seen that there is a delayed recovery for these patients, and the PSF took a longer time to settle down. So basically, for those patients, my go-to procedure is Contura. Uh, or surface ablation, depending on what is the nature. But otherwise, I think for femtoLASIK or topo-guided femtoLASIK, there is really no upper limit. Yeah.
Perfect, perfect.
I think I agree to know this point. Smile, we have not gone for a more than the highest age I have done is around 30, 32.
Yeah.
Because we know that if something happens, which is bound to happen in an older age group, regression things, then resurgery is very difficult at smile, and that's why the femtosecond laser will be the better in these cases for making flap and subsequently doing procedures. So still, whatever we think of resurgery in a smile is a challenging still, and sometimes you are very lucky. I've done recently few of making cap to flap in some patients,
Circle.
and it was so surprising to me to see when I removed the flap, the stroma was looking rough. That I remembered my days of making, the flap with the, keratome or a flap with the femtosecond laser. You see the bed, with keratome, it is a smooth bed. So
Yeah.
that's the difference, which is in these cases of femtosecond laser. Whatever you do femtosecond laser, it cannot make the cut of a keratome.
Right. I agree. I agree, sir. Absolutely. Yes. Yes.
Dr. Kaushik, I think we had a wonderful discussion,
And the
and
idea of also I like the smile in a nystagmus patient.
Yeah.
I'll take it.
Thank you, sir.
These all were very important points. Yeah,
या
really.
अरे कौशिक तुमने कुछ बताया नहीं रेटिनल प्रोसीजर मैंने इतना ध्यान से बोला यार व्हाट्स योर कमेंट ऑन दैट
Sir, we actually do laser everything which is present before LASIK, like even asymptomatic lattices, asymptomatic holes, but whatever predisposing lesions are there, we are treating those before LASIK. Any predisposing lesion.
Actually, we are going to come out with a series now where our younger colleagues, Soria and two more people are doing pre and post assessment of which Farin could not complete. They're completing the series of patients where we're doing not only looking for a vitreous only, we are looking everything right from the now fiber layer to we are doing the or what do you call the blood supply, other things that we are looking on that. So maybe we'll have something coming. We are comparing the smile versus the femtosecond LASIK.
Nice.
Yeah.
I think, sir, it was an excellent talk and excellent discussion. We have had many refractive surgeons from our side and international surgeons also, and we definitely learned a lot today. And this was a lively discussion, and audience, the questions of audience was also good, specifically in it was like eye opener for us. I'll thank you, sir, for sparing your valuable time with us. And this video will be available on our YouTube channel. And I thank Dr. Vardhaman, Dr. Sourabh, Dr. Mayank, Dr. Farin, Dr. Hemant for making the discussion lively. And I think with permission from the sir, we'll close this. And I'll thank my
Just I'd
colleagues.
like to say one last word.
Yes,
Like,
sir.
I know that, you people are so close to me and the entire age group. And I initially I kept telling, Arun to, start academic programs, like start academic programs. It is so heartening to see you people are doing so well in this field also, especially the young brigade, Kaushik and all, looking into this aspect because you have quite a large group and you have a responsibility for getting them to the academics also, and this will also help you to generate the future, not only clinical side, you can have a research wing open subsequently also, and younger people joining you for a fellowships and other things, because it's not only the expansion of your clinical services, it is ultimately taking everybody together to a next level. And we know that things are going to be brighter, much more innovative things are going to come. And if I see my 45 years into medical area, see how much changes happen in every decade. Things are going jumping to the newer heights. So this is how I think things are. I'm very happy that you people are doing such a great work in this area also. I wish you all the best and keep doing good work.
Yes, sir. Thank you, sir. We are already having our fellowship programs in medical retina, phaco-refractive,
Yeah.
and retina. And Dr. Ganesh is leading the fellowship program, and we have Dr. Mayank and Dr. Actually, this idea of the webinars came from Dr. Atul Dhawan. So we started with international faculty, and then we we are doing national faculties also, and we have actually learned so much because people with experience, like, we are actually this experience talks, and we actually learn from your experience, sir. Thank you. Thank you, sir. Have a good day.
Thank you.
Thank you. Thank you, sir.
Thank you, sir.
Thank you. Thank you. Thank you so much, everybody. Thank you.
everyone.
Thank you, Dr. Titiyal, sir. Thank you.
Good night. Good
Thank you,
night.
Dr.
Bye-bye.
Kaushik and the team. Yes, thank you. Thank you so much.